Hello everybody, welcome back to DaVinci Academy's Chapter 7 unit of the head and neck, our lecture here on the oral cavity and the oropharynx. So the oral cavity is a very unique area in the anatomy because it has a lot of different functions. It is composed in the region anterior to the pharyngeal arches, so the arches would be here, and it's kind of considered to be posterior to the lips. The lips are here, and it's kind of confined in this region over to the right. So it's often divided up into two different areas, the oral vestibule and the oral cavity proper. So the oral cavity is important because it helps with speech, mastication, gustation, breathing, and even early digestion, making the food bolus. So the contents of the oral vestibule consist of things like the lips and the cheeks outside the dental arches. And the contents of the oral cavity proper include things like the teeth, both maxillar and mandibular arches, the buccal surfaces, as well as the hard, soft palate and that tongue right here. So when we talk about the oral vestibule, it's important to first mention the lips. So the lips are very unique soft tissue structures that are composed of both mucosal and cutaneous surfaces. They also have muscular and fibrous components that contribute to opening and closing of the mouth. So the main muscles that help with movement of the mouth and the lips include the orbicularis oris, which actually acts like a sphincter as it wraps around the mouth, and the superior labial and the inferior labial help with both elevation and depression of the lips. So when we talk about the orbicularis oris, it's also very important to talk about this structure right here. That's called the philtrum. So the philtrum is this little depressed region right underneath the nose, right underneath the camella, right above the upper lip. So the philtrum is actually a medial depression, and it actually runs from the lip to that columella. And the reason why it does have a depression is because your orbicularis oris actually has fibers that decussate across this depression. And they actually insert into the lateral philtrum columns. And what happens is because there's no insertion right in the middle here, it forms a depression point. So the next other component that's important about the lips is the vermilion, and this is this region right here. This is like the red region of your lips. This is where you put your lipstick, this is where you put your chapstick on, and this is what shares both the wet and dry mucosal lining. Then you have your commissures, and your commissures are these corners of your lips right on the outside here, and these are important because this is just where the lateral portion of your upper lips kind of meet. And what's important is that any sort of defects here, whether it's a contracture or a burn or something that's very significant, can actually make your mouth smaller and hard to open your mouth, to breathe, to talk, to eat. So you sometimes have to do like an advancement and actually try to cut and do like a commissuroplasty and actually open up the mouth that way. So when we also talk about the lips, there's a difference in the anatomy of the upper lip versus lower lip. So the upper lip receives blood from the labial artery and the infraorbital artery, and the venous drainage kind of parallels that. The innervation is provided by the maxillary nerve. The difference is that the lower lip is provided by the inferior labial, again the venous drainage parallels the arteries, and then the innervation is again provided by the mandibular. And so it just differs in terms of the arterial supply as well as the innervation supply. So when we talk about the oral vestibule, it's also important to mention the cheeks and lingual mucosa. So when we talk about the cheeks, this is the mouth, nose, eye. People think that this region right here where the teeth are, this would be your cheeks. However, your cheeks actually are everywhere, all the way out to your ear, including that area right by your teeth, and even a little bit below that. So this is considered to be your whole cheek region. So your cheeks are considered to be movable structures, and they're kind of lateral to the oral cavity, and they're moved by structures like the buccinator muscle, which is the primary muscle of the cheeks. The blood supply to the cheeks are by the buccal mucosa and the buccal artery. The cheeks receive blood supply from other structures, including the infraorbital artery, the transverse facial, and zygomatical facial artery. And the lingual mucosa, as the membrane, actually receives blood from the lingual branch of the inferior alveolar artery. And again, much like everything else, the venous drainage just parallels that. And the innervation to the cheeks can be provided by branches like the PSA, the MSA, the ASA, and the maxillary area, as well as branches off from the mandibular as well. So now we'll talk about the oral cavity proper. So the oral cavity proper is composed of the teeth. So the teeth are these bony structures that are located in the alveolar process in both the alveolar ridge, the maxillary, and the mandibular bone. So your teeth are pretty much divided into two different periods in time. You have your primary teeth, quote unquote, your baby teeth, and those are composed of 20 teeth. Then you have your 32 primary teeth, or permanent teeth, that are fixated after your primary teeth have been removed or fallen out. So your teeth are important because they actually help with speech, and they actually aid in that really fine articulation and that phonetics. Because anytime you've ever heard someone who has false teeth or had no teeth, you could oftentimes pick it up without actually knowing that they have no teeth because the way that they can't articulate their words as properly. So the teeth is actually a very unique structure, and it's probably outside the scope of what we're going to talk about. It's probably important for people that are in dental school. But anyway, the teeth are composed of a really tough structure called enamel, as well as by a structure called dentin and cementum. So the innermost part of the tooth is called the chamber, And this houses the pulpal nerve, which is what provides that sensation and that innervation to the teeth. So all teeth are composed of a crown and a root. So the enamel and the cementum serve to protect the body and underlying layers of the teeth. The apex of the root is where the innervation and the blood supply enters, so right about here. So you imagine this is the tooth, and then this is my apex of the tooth, this is my root, and this is where I have my arteries and my nerves coming in. So the teeth, blood supply, and innervation. So this can be little fine details and what's going on. You can read up on it if you want, but this is more just for clarity and transparency's sake. So just bear with me through this section because this is probably, again, something that's more relevant for people in like dental school. Anyway, so your teeth and blood supply and innervation. So again, they have sympathetic and sensory innervation to the teeth. The inferior nerve and vessels provide innervation to the mandibular dentition. The incisive nerve and vessels provide blood to the supply to the mandibular incisors, canines, and first premolars, which is a branch of the inferior alveolar nerve. The PSA nerve provides blood and arteries provide blood supply to the maxillary molars. You can think about that, the posterior aspect, right? The backside is going to be where your molars are. The infraorbital nerve and vessels provide blood to supply innervation to some of the maxillary teeth, not all of them, and occasionally they may not. The MSA, like we said before, it could be absent, and then if it is absent, the ASA would take over. It can provide sensation to the first molars as well as to the maxillary premolars, and the ASA provides sensation to the maxillary canines and incisors. And like everything else, the venous drainage runs parallel to all these arteries. So now we'll talk about the gingiva or the gums. So the gingiva is made up of keratinized and non-keratinized tissue, and it depends on the location inside the oral cavity in which this exists. So for the keratinized tissue, this is attached to the gingiva, located closest to and surrounding the teeth, and it's on the hard palate. It's the non-keratinized tissue, it's in the free gingiva located more apically out to the teeth. It is located on the soft palate, the floor of the oral cavity, labial and buccal mucosa. So I think of the keratinized ones by the teeth, and I think of the non-keratinized one not near the teeth. And that's pretty much how I figured it out. Other than that, there's probably not much more you need to know about this. So the gingiva gums, this is the blood supply innervation corresponds with the tooth that's in close proximity, and that's pretty much all you need to know. So if you have teeth that are close to the buccal area, buccal gingiva, you're going to get sensory V3, lingual, again, V3, and then venous, again, of course, always parallels the arteries. So we'll talk about the hard palate for a second. So we mentioned it in the past, the hard palate has a greater palatine canal, has an incisive foramen, has a hard palate, has a soft palate, but anyway, the structures of the hard palate are composed of an alveolar process of the maxilla, two maxillary bones, the horizontal plate of the two palatine bones. It has the incisive papilla and the transverse palatine folds or the rugae that's going to be located on the top of the mouth as well as the palatine raft. So it's a lot of words, there's a lot of things to know. You probably don't need to know. All you need to know is it's composed of like the palatine bone and it's composed of the maxilla. That's probably all you need to know. So superior to the hard palate is the nasal cavity, as you know, as well as the maxillary sinus. That's why you can get maxillary sinus infections with maxillary teeth extractions. Blood supply to the hard palate is the greater palatine artery, and the innervation is the greater palatine nerve, and the nasopalatine nerves as they come through right here through that incisive foramen. And here, greater palatine to the greater palate. And then for the greater palate, you also have the soft palate, and this is the posterior region of the palate and the oral cavity that really does not consist of any hard bony structures. It's soft. That's why it's called soft palate. This is composed of things like the uvula, the palatine aponeurosis, the palatal arches, the palatal folds. It has the palatine tonsors, the pillars of fauces, the tonsillar sinus, as well as the muscles of the soft palate. So again, it's not like it's going to be difficult to pick this up. I mean, you know where the soft palate is, you know where the hard palate is, and that's pretty much all you need to know. It's important, though, to note that the palatal glossal and the palatal pharyngeal arches serve as the boundary between the oral cavity and the oral pharynx. So when you think it's like these arches are like entranceway into the deep portion of the oral pharynx. So when we talk about the oral cavity proper and we talk about the soft palate, we also have to talk about the muscles that are in close proximity to that, and that includes things like the tensor veli palatini, which tenses or kind of retracts the eustachian tube. You have the levator veli palatini, which kind of lifts or elevates the eustachian tube, muscularis uvula, your palatal pharyngeus, and your palatal glossal. Those are kind of the 5 muscles that are associated with the soft palate. And as you can see over here, this is your eustachian tube. And then you would expect, you can't really see it from this side, but you expect your muscles coming from this direction, your tensor veli palatini, your levator veli palatini, to do its associated functions. And with the soft palate, just as we mentioned before, you have arterial fibers, arterial vessels that come down through the greater palatine canal and then become the lesser palatine artery, provide blood to the lesser palatine area. So lesser palatine artery to that area. And again, venous parallels the arteries. Innervation is via the greater and lesser palatine nerves, and most notably is with the lesser palatine nerves. So now we'll talk about the floor of the oral cavity. So the floor of the oral cavity houses many structures like the lingual nerve, the mylohyoid muscles, the geniohyoid muscle, the tongue, submandibular, and sublingual glands. So the mylohyoid muscle actually offers support to the floor of the oral cavity and actually helps with stabilizing the tongue. The geniohyoid actually helps with overlies the mylohyoid muscle and does a pretty similar function. You also have a little structure called the sublingual caruncle. So the sublingual caruncle is it's like a submandibular duct for the submandibular gland, and that's pretty much all it is. I just like testing it because it's just a unique and different name. So then again, here are the muscles of the soft palate. You can take a little index card like I like to do, cover one up, then kind of test yourself and quiz yourself that way. But the most important thing to note is just look for the difference makers here. Well, of course, I always go straight to nerves because they're so easy to pick up on. All of them are vagus, right? All of them are vagus except for this one. Tensor veli palatini is V3. And if you know that, then you'll be pretty good. And the other ones you need to know, just know that this tenses via the word tensor. This elevates via the word levator. And that's pretty good. That helps quite a bit. And then everything else you can kind of quiz on your own. So now we're going to go talk about the tongue. So the tongue is a very important structure. It's a very muscular structure and considered to be like per square inch the most strong, most muscular portion in the body aside from the female uterus. It's important for things like mastication, phonation, swallowing functions, and it's easily divided into two areas, the anterior and posterior regions. So the anterior tongue is composed of things like the midline septum, the papilla, and the dorsum, and the apex. The sulcus terminalis divides the posterior and anterior regions of the tongue. And that pretty much helps with delineating the two, especially with something like taste sensation. You also have the foramen cecum. This is actually the primitive embryological origination of the thyroid gland. This is actually where the thyroid gland will descend from. And it's at that point where you can actually even get thyroglossal cysts or even some remnant thyroid gland actually in the base of the tongue. And also in the posterior tongue, you have the lingual tonsils as well as the oropharynx once you pass those palatal arches. So the tongue muscles are divided into two. You got the extrinsic tongue muscles, which control the movement, the raw movements of the tongue, like elevation, left, right, the big cardinal directions. Think by things and muscles like styloglossus, genioglossus, hyoglossus, and palatal-glossus. And then you also have, well, here's the chart as well outlining those two. Again, just take an index card, kind of quiz yourself. Origin insertion is pretty self-explanatory. Styloglossus, genioglossus, hyoglossus, palatal-glossus. But look for the hallmarks. Look for the difference makers. And again, like I always say, it's like innervation. The nerves, for some reason, are often tested on because they just can get really confusing. So these three are all by hypoglossal, but this one is by vagus. Palatal-glossus is the only one of the extrinsic tongue muscles that is by vagus. Now, that's something to keep important. It's something to know. And then when you have the extrinsic, you also have the intrinsic. So the intrinsic tongue muscles are unique because these are the ones that are actually within the tongue belly itself. They kind of interdigitate within the tongue. And this is important because they kind of do like the really fine movements like, making a four-leaf clover or rolling your tongue. They have no bony sites of attachment. They kind of just spread out within the muscle belly of the tongue. And there's 4 of them. However, you're probably not going to get tested on this because there's such insignificant clinical problems associated with them. So with the tongue, the blood supply is unique because it's provided by the lingual artery, which is a branch off the ECA. However, it's important that the left and right lingual arteries don't communicate. So you would think in a muscle belly like that, and it's such a small structure that the left and right can form some sort of anastomotic branches, but they really don't. You can actually dissect the tongue and actually separate the left and right lingual arteries out. You also have a sublingual and deep lingual arteries as well as a tonsillar artery. And again, of course, you'll never forget it, venous drainage just parallels the artery. In terms of innervation to the tongue, you have your lingual nerve, which is of the mandibular, which provides just sensation to the anterior 2/3. You have your chorda tympani, which is a facial that provides taste to the anterior 2/3. Then you got your glossopharyngeal that literally does taste and sensation to the posterior 1/3. And of course, vagus, gotta include vagus, can't exclude it, has a little bit of sensation, a little bit of taste to really, really far back in the posterior aspect of the tongue as well as the epiglottis. So when we talk about the tongue, it's important to talk about the taste buds that are present on the tongue. So you have 4 different ones. You have the circumvallate papilla, you have the fungiform papilla, the filiform papilla, and the foliate papilla. So the circumvallate papilla, this does contain taste buds, and this is controlled by the glossopharyngeal. This one is located in the posterior border of the dorsal tongue, and it's located anterior to and run parallel to the terminal sulcus and arranged in the V pattern. So if this is the tongue, right, you're going to actually have like a V shape like this. And this is where you're going to have the circumvallate papilla kind of present. Your fungiform papilla, and this also is considered to be taste buds. This is provided by chordate tympany off of facial. This has mechanical and thermal receptors, and this is located on the dorsum of the tongue and resemble mushrooms in appearance and shape. These guys. Then you have your filiform papilla. This one has no taste buds, so this is one that you're going to want to remember. Taste buds, yes. Taste buds, yes. Folate, of course, no, none. And this is also present on the dorsum. So then you have the folate papilla, and this is also taste buds. This is also by chordate tympany, which is a V7 of facial nerve 7. And this is located in the lateral portion of the tongue. So you're going to get your folate over here on the lateral portion. You're going to get your circumvallate over here in this V-like area. Then you're going to get both fungiform and filiform located on the dorsum of the tongue. However, it's the filiform that really does not have any taste buds at all. So again, take this a little slower if you have to, but just know, the biggest things to know, this is glossopharyngeal. This has no taste buds. Dorsum, this is lateral. And then you know that the fact that these are chordate tympany. And you'll be good to go. So when we talk about taste sensation, this is kind of interesting to talk about. So the apex of the tongue, right around here, actually, this is where you detect sweetness. Laterally, over here, this is where you detect saltiness. And then posterior area, this is where you would detect the sourness and bitterness. So now we're going to mention the salivary glands. So there's actually quite a lot of salivary glands. It's divided into your major salivary glands and then your minor salivary glands. So one of the major salivary, or the largest salivary gland, is the parotid gland, and it contains both the production of serous saliva. It has important anatomical relations to mention that we'll just go through right now. So the facial nerve, as we mentioned, passes through the superficial and deep lobes. The external carotid artery travels upward and through the parotid gland prior to branching into the maxillary and superficial temporal branches as its terminal branches. The superficial temporal and maxillary vein actually join around the parotid gland to form the retromandibular vein. It also is located laterally posteriorly to the ramus of the mandible and rests below the inferior border of the mandible, you can see right here. And then the zygomatic arch is situated above the parotid gland, so like zygomatic arch right there. And the sternocleidomastoid muscle is located posteriorly to it, so then here's the sternocleidomastoid. And just anterior to the parotid gland is the masseter muscle right there. So this is a great picture over here to the right. And then confining the parotid capsule and sheath is made as the deep cervical fascia investing layer, as we talked about before. Remember, there are 4 layers of the deep cervical fascia, and the investing layer is the first layer, and that is what is confined within the parotid gland. So the parotid gland actually receives innervation via the auriculotemporal nerve, sensory and autonomic innervation via the postganglionic parasympathetic fibers from otic, which is of glossopharyngeal. You also get the greater auricular nerve, excuse me, which provides sensation innervation to the parotid fascia. You also get sympathetic nerves, much like everything else, and this helps with decreasing salivary flow via the vasculature. Then the duct that actually connects the parotid gland to the oral cavity is called the Stenson's duct. And from the anterior parotid gland across the masseter muscle medially, it can actually course through the buccinator muscle into the oral cavity, and it's located right around the maxillary second molar on the buccal surface. That's where you're going to find it. So if you look across, this is the first molar, this would be the second molar, so you'd expect the parotid Stenson's duct to be right around there. So next we'll talk about the sublingual glands. So the sublingual glands, these are the smallest of the major salivary glands. They primarily produce mucus secretions. It's located medial to the mandible. It sits on the floor of the oral cavity, in the sublingual fossa, under the tongue, and lateral to the genial glossus muscle. The lingual nerve and ducts of the submandibular glands run bilaterally and medially to the sublingual glands. So the sublingual glands are actually innervated by the chordate tympany and carry parasympathetic fibers to the submandibular ganglion. Sympathetic nerve fibers, of course, just control salivary flow. The sublingual papilla serve as the location and drainage into the oral cavity from the submandibular and the sublingual ducts. So the Bartholin's duct actually connects the submandibular duct to the oral cavity. So you got Stenson's for parotid and you got Bartholin's for sublingual. Now we'll talk about the submandibular. So the submandibular are like the intermediate, the medium-sized major salivary glands, and they produce serous and mucus secretions. This is located in that submandibular triangle that we talked about before, inferior to the mandible. Anterior is the anterior belly of the digastric. Posteriorly is the posterior belly of the digastric. It wraps around the mylohyoid muscle, and part of the gland is actually located within the oral cavity on the side of the hyoglossus muscle. And at the base of the tongue, part of the outside of the oral cavity is the submandibular fossa. So the lingual nerve actually will course anterior-medially, starting lateral and superior to this. The marginal mandibular nerve, which is a branch off the facial, actually travels down and below the submandibular gland right around the mandible pole. And the hypoglossal nerve is located deep to the submandibular gland. And it's actually very interesting. If you can find the submandibular gland, you can actually have an easy time of finding the hypoglossal nerve. So the submandibular glands are also innervated by the chordate tympani with parasympathetic fibers, the submandibular ganglion, and of course sympathetic controls salivary flow. So you had your Stensons, you had your Bartholins, and now you have your Whartons. So your Wharton's duct excretes salivary contents into the oral cavity from the submandibular glands. This travels between the mylohyoid and the genioglossus and hyoglossus muscles and opens up into what we call a sublingual caruncle at the floor of the mouth. Right there. Posterior to the mandibular incisors. So you would expect to see Whartons right there. And then while we have major, we also have the minor. And the minor really are unnamed. There are thousands of them. So they exist throughout the oral cavity. They can be in anywhere in the labial, palatine, buccal, and even the pharyngeal glands, all over the whole mouth. So now we're going to talk about the oropharynx. So the oropharynx is a region of the head that's located between like C2 to C3, posterior to the pharyngeal arches that we mentioned before, between the uvula and between the epiglottis. It contains a soft palate, the posterior tongue, the tonsillar beds, the palatine and lingual tonsors, as well as the mucosal surfaces along the eustachian tube opening, as well as the pharyngeal wall constrictors. So you have your palatoglossal arch, which constructs the oropharyngeal isthmus. If you can see over here to the right, this is your arch. And then this is also your arch. So right after these arches, that is where your oropharynx kind of begins. So when we talk about when an individual swallows, this isthmus that we talked about actually opens, and the laryngeal cavity will close, and the palate will rise. This allows food to kind of descend down into the mouth. So you can breathe with food or liquid in the oral cavity, but because oropharyngeal isthmus closes, when you try to swallow and the palate depresses, the tongue moves backwards and you cannot breathe anymore, preventing the flux of food. And because even though it's temporary, you can't breathe. So if you ever tried to swallow and breathe at the same time, you wouldn't be able to, because the isthmus, when it closes, it obstructs your ability to breathe. So now I'm just going to break down the stages of swallowing real quick. So stage 1 is voluntary. It's where you chew, you make your bolus, and you start to initiate into the back of the throat. Stage 2 is involuntary. It occurs quite rapidly. Your soft palate elevates. It closes off the nasopharynx. The bolus moves down. The larynx then elevates via continuation of the suprahyoid muscles doing their thing. And then stage 3 is also involuntary, where the bolus enters the food, enters into the esophagus, and then peristalsis takes over. So it's not bad. It's not something you have to really worry about. So stage 1 is voluntary. It's the only voluntary one. Then stage 2 and stage 3 are involuntary. Voluntary is where you just chew and move the food back. Involuntary with stage 2 is where you have to actually start closing off and elevating the soft palate to close off the nasopharynx. And then stage 3, the involuntary portion, is where the peristalsis takes over. And when we talk about the oropharynx innervation, it is innervated by the pharyngeal plexus. This is composed of both 9 and 10. However, all motor innervation to the pharynx is actually provided by just the vagus, except for the stylopharyngeus, which is the glossopharyngeal nerve. Because the glossopharyngeal nerve, this is your stylar process, and then you have your stylopharyngeus muscle. Your glossopharyngeal nerve actually runs around the course of the stylar process, as well as the stylopharyngeal muscle. So it's easy to imagine that it's going to innervate as it passes right along this muscle. And then the blood supply to the oropharynx includes the ascending pharyngeal, facial, maxillary, superior thyroid, and lingual artery branches from the ECA. And of course, venous always parallels. So with the oropharynx, we're also going to talk about the oropharyngeal arches that we mentioned before. It's composed of those two. As you can see here, you have your palatoglossal, and you also have your palatopharyngeal in the back. So palatoglossal closer to the tongue, palatopharyngeal closer to those pharyngeal constrictors. And then you have your oropharyngeal muscles. And these are honestly very low yield, but for completeness sake, we'll mention them. Your salpingopharyngeus, your stylopharyngeus, which remember is cranial nerve 9. You have your palatopharyngeus, and then you have your constrictors. And within each of these constrictors, they actually have named components of those as well. However, it's probably not important to really know what those are. Just know that your superior pharyngeal constrictor, your middle, and your inferior, and it's all controlled by vagus motor. Then you have your uvula. This is just a little muscular mucosal tissue that hangs down from the soft palate. It's innervated by vagus. The recurrent laryngeal nerve and external laryngeal nerve actually help provide some sensation and via the lesser palatine nerve as well. You have little mucosal pouches, and these are like depressions that are located on both sides of the midline where the base of the tongue actually connects to the epiglottis. So if you imagine right here, it's hard to see, but you would have a pocket on this side, and you have a pocket on the other side of the tongue. And of course, we'll talk about the eustachian tubes, also called the pharyngotympanic tube. It connects the middle ear to the oral cavity. It just helps with equalizing middle ear pressure, as well as help with the drainage of the middle ear. And then of course you have your tonsils, and this is actually lymphatic tissue that is in the pharynx. It just helps with immunological protection. It's supplied by the tonsillar artery and receives innervation via the tonsillar plexus of the nerves, both glossopharyngeal and vagus. And you can even see right here, there's some tonsillar tissues right there and right there. It's actually very easy to see in people, especially when they have a very large oral cavity and oropharynx. So we talk about the tonsils. There's actually a structure called the Waldeier's rings, and this is actually a ring of lymphatic tissue that actually circumferentially surrounds the oral cavity oropharynx, kind of like in this, kind of like this. And it just provides like a protection, a circular protection of tonsillar lymphoid tissue for any sort of infections that come into the mouth. So you have adenoids, which are probably considered to be the ones up top here, located in the nasopharynx. You have your palatal tonsils, which are the ones here. And these are formed from the superior pharyngeal constrictor muscle and the pharyngobasilar fascia. You have your lingual tonsors, located posteriorly and below the tongue. You have your tubal tonsils are located around the opening of the eustachian tubes, so probably more back up in here. And then you have your lateral bands at the salpingo fold. So as you can see, you just have this circumferential orientation of these lymphoid tissue that kind of surround the mouth, called the Waldeier's rings. Now I'm going to discuss some clinical pearls. So in terms of the oral cavity oropharynx, you can get a thing called tonsillitis and peritonsillar tissue inflammation. So palatine tonsils are capable of becoming inflamed and obstructed and infected, just like anything else in the body can. And when those tonsils become enlarged and inflamed and infected, you can have to have them removed because they can obstruct the airway, and just be a surgical procedure called tonsillectomy. However, during tonsillectomies, bleeding can be significant, so you have to make sure that you actually avoid damage to the glossopharyngeal nerve when you're trying to control hemostasis. And especially the ICA artery is really close proximity to the pharyngeal wall. You have to make sure that you don't for any reason injure that during your dissection. You could also get tonsillar infection, can actually spread to the peritonsillar tissue itself. And when that happens, you can get a thing called quinsy, which is when the uvula will actually deviate to one side. And when the uvula deviates, you know it's peritonsillar. It's like guaranteed. So the deviation of the uvula can obstruct the pharynx and even obstruct breathing at that point. So quinsy is an indication of infection, of spread, and abscess formation. So this one would specifically be treated with some sort of incision, drainage, clearing out the infectious contents, and possibly antibiotic treatment. You can also get obstruction of the pharyngotympanic tube. So it can occur if either the tubal tonsils or the pharyngeal tonsils swell, enlarge, and obstruct that tube. This can prevent equalization release of the middle ear, and which can result in excess pressures in the middle ear and even perforation of the tympanic membrane and middle ear damage and potentially hearing loss. So for some instances, like in children, they can develop like polyps, and which is a common reason why pharyngeal tonsils can enlarge and include the auditory tube and cause some sort of remote hearing loss in children. You can also get a thing called hairy tongue, which is often very confusing, especially with like hairy leukoplakia, hairy tongue. So all in all, hairy tongue is just desquamation of the filiform papillo, where it grows longer than its normal size due to excess keratin building up. So it's just a common clinical presentation, nothing to really worry about. Usually presents in people with dry mouth who are dehydrated, or even sometimes even certain medications in smokers. You can get some like hairy leukoplakia, where other symptoms where like this is actually related to other more significant pathological concerns. But if you just have something like a hairy tongue, someone actually describes like, cotton mouth, like, they're exercising a lot, they're running a lot, they're talking a lot, and they're getting cotton mouth, that's considered to be like a hairy tongue. And that's just literally caused by like dehydration, dry mouth because of excess keratin buildup. Then you can get a thing called ankyloglossia, which is tongue-tied, in which you have a little structure right here in the base of the tongue called the frenulum. So this little frenulum right here can actually be shorter in some people, and then they can be tongue-tied because they cannot move their tongue as much as they want. Their flexibility is limited. At that point, all you gotta do is just cut it, do a little frenulectomy, and then pretty much their speech and everything can resume back to normal function. You can get submandibular surgery nerve damage, and in this instance, you can have damage to the lingual nerve. And if this happens, you just a loss of sensation and taste the anterior 2/3 of the tongue because the chorda tympani runs along with it. You can also get damage to the marginal mandibular nerve. So this is actually a branch of the facial. So then you'll have muscle weakness, paralysis, and like the lower face there, the depressor labii inferioris. You can get drooping of the angle and the lower lip of the mandible, as well as paralyzation of the muscles of the chin. You can also get damage to the hypoglossal nerve, cranial nerve 12. And at that point, you just weaken and paralyze the muscles of the tongue. So you can have speech impediments, difficulties, and even you can notice some sort of tongue deviation to the side of the lesion based on the fact that back in the cranial nerve lecture, any sort of defect with tongue innervation will cause you to lick your own wounds. So now we'll talk about tumors of the salivary glands in brief. So the parotid gland is a very common site for salivary gland tumors, and all in all, parotid gland tumors are usually benign. However, they can grow, and they can grow pretty large, and they can go to a significant point where it actually can destruct a lot of the neighboring normal anatomy, and you have to have pretty gross in-block dissections to remove it all and do complex flap reconstructions. But the big thing to note is that they're usually benign, but whenever you have facial nerve involvement, then that's when you think it to be a little bit more malignant. That's just the hallmark there. So then there's another thing called parotiditis. This is where you get inflammation of the parotid gland. So this can be seen like viral diseases like mumps. This is where it becomes very painful, to tough sensation, and even some sort of times you can get enlargement and swelling of the parotid gland. So the parotid gland is an encapsulated structure with a fibrous sheath. So anytime there's inflammation and swelling, this will actually enlarge. And of course, if this gets enlarged, it can compress the facial nerve and show signs like Bell's palsy or things like associated with facial paralysis. Then you can also get silolis. These are just like little stones that can exist in the salivary glands. They're just little stones that deposit in the ducts, and it's pretty much you just have to try to either keep your fluid hydration up, or have to sometimes even go in and remove these little stones. And sometimes they even occur because of the fact that there's these long pathways, these long tortuous ducts to go from the glands all the way to the oral cavity, that the salivary secretions can actually accumulate, build up, and then depositing stones. And they can be painful, and they can be very symptomatic of blocking the orifice, or they can be sometimes even asymptomatic, and then you just notice like a lump in the mouth. Diagnostic testing for this is using a silogram, which is just inject some dye, and just to see if the dye will actually be emitted or not. And then if that's the case, sometimes you have to do some sort of like local surgical resection and remove the stone. And then again, we have the infamous cleft lip and cleft palate. So with cleft lip, it's usually a defect that occurs during fetal development. This is when there's an interruption in the fusion of certain facial processes. So the median nasal and the lateral processes, they will actually fuse together, and they form a normal lip. So this is how. So you get lateral fusion, and you get inferior fusion, and together you should form a nice complete lip, like this. So if that doesn't happen for any reason, you can get a cleft lip. So cleft lip and cleft palate are actually isolated diseases. They actually are not thought of to be one and the same. There are certain syndromic diseases where the cleft lip and cleft palate can actually rise together, but pathophysiologically, cleft lip and cleft palate are, for all intents and purposes, just very different diseases. In terms of cleft lips, you can get a unilateral, which is only one side is defected. You can get unilateral incomplete or complete. So complete would go all the way up to the nose. Incomplete would probably just end like right around the mid aspect. Then you can get bilateral complete as well, where both of them are up like here. And this lesion will actually come up and like lift up off the mouth, and that's called like a flyaway effect, or flyaway portion of it. With cleft palate, this occurs when the palatine shelves actually do not fuse in normal embryological processes in utero. This is usually just caused by some sort of disruption or fusion of the palatine shelves, and usually it's right around here is where you're going to get that cleft lip, cleft palate, and then here is where you can see that cleft palate, that wide gaping. And usually, sometimes if they don't pick it up in a newborn examination, it maybe presents because the child will have inability to breastfeed. Because without having a nice hard palate, when you have any sort of hole inside the hard palate, you actually will have decreased ability for the child to latch onto the nipple. And like I said before, cleft lip, cleft palate can be developmental disorders. They can come from syndromic problems like Pierre-Robin syndrome, or it could also be non-syndromic or just idiopathic for no reason whatsoever. Thank you very much. That concludes this unit on the oral cavity and oropharynx. Again, that's a lot of information. There's a lot of topics to go over. Try to make sure you memorize the high yield things. There's a lot of content in this chapter that may be considered lower yield. Try to just pick up on the high yield clinical situations, and this will be a section of anatomy that's actually fairly easy for you. Thank you.